Today I would like to share our study about diagnostic accuracy of benign vertigo in different specialties. As we know, vertigo can be the primary presentation of stroke, but this stroke is easily misdiagnosed as benign vertigo, especially if the vertigo is not associated with focal neurological signs. According to the previous studies, patients discharged with benign vertigo have higher stroke risk than general population, but we don't know if this higher risk is associated with different medical specialties. So our study is to compare stroke risk among patients discharged with benign vertigo across different medical specialties. Our study is a population-based retrospective study using the National Claim Database of Taiwan. This is a big database including around 1 million people in Taiwan. And we compare the stroke risk of patients diagnosed with benign vertigo by the doctors in neurology, otolaryngology, internal medicine, and family medicine clinics. And then we combine neurology and otolaryngology to be the specialty care group, and combine the internal medicine and family medicine to be the general care group, and compare the stroke risk between these two groups. Okay, this is the study flow chart. Initially, we include all patients diagnosed with first instant vertigo, meaning that first vertigo and seeing the first doctor in the clinics between 2002 and 2009. And then we excluded the patients with dangerous vertigo that their doctor suspected. So we excluded the patients referred to the emergency room and the patients who were admitted on the same day of the index clinic visit. And then we excluded the patients diagnosed with stroke at the index clinic visit. Furtherly, we excluded the patients diagnosed with central type vertigo at the index clinic visit. After we excluded these three groups of what we call dangerous vertigo that their doctor suspected, the residual patients were the benign vertigo patients that their doctor impressed. And then we classify these benign vertigo patients into 5 groups according to where they got the diagnosis: in neurology clinic, otolaryngology, internal medicine, family medicine, or other clinics. But we excluded the last group, other clinics, because most the other clinics mainly contain the pediatrics clinics and Chinese medicine clinics. So this population is largely different from the other 4 populations in these groups. So we excluded it and only compared these 4 groups. And then we combine these 2 groups as the specialty care, and combine these 2 groups as the general care group, and compare stroke risk between each other. Okay, let's see the result. This is what we call the Kaplan-Meier curve, representing the long-term stroke risk among different specialties. As the result, the cumulative stroke risk in patients diagnosed as benign vertigo by their doctors are different in different specialties. Highest in internal medicine, and then family medicine, neurology, and lowest in otolaryngology. So from this curve, we can see that the ENT doctors looks good, but unfortunately, I'm a neurologist. But the different long-term stroke risk across different specialties may be not only related to the different misdiagnosis rates, but also related to the different baseline stroke rates. What is the different baseline stroke rates? Let's see this table. The patients visiting otolaryngology clinics were younger than other groups. And do you find that? The patients visiting internal medicine group had more hypertension and more diabetes than other groups. So the populations in these 4 groups are largely different. So we say that different stroke rates may result from different populations with different baseline stroke rates, not only related to the difference of misdiagnosis. So we call this as referral bias. And the referral bias of our study may make these four groups incomparable. So it's unfair to compare them. So that's the problem. How can we deal with this problem? Then at the next step, the first question we need to answer is, are there really diagnostic errors in these benign vertigo patients? So let's see these four figures. If there is no diagnostic error, stroke incidence rates in each month should be constant, not temporally related to the vertigo diagnosis dates. However, in these four figures, four temporal profiles, we can see that the first month's stroke incidence is higher after benign vertigo diagnosis, is higher than other months. This condition occurs in all the groups, right? The first one bar is highest. So this condition implies us that there must be an early recurrence of stroke after benign vertigo diagnosis. So I think this is a strong evidence of diagnostic errors. And then this is the quantitative data. If we define certain stroke rates as the first month stroke incidence after benign vertigo diagnosis, and we define the long-term stroke rates as the monthly stroke incidence in the average of the second and third years after benign vertigo diagnosis, and then we compare the short-term rates to the long-term rates. And let's see these tables. This is incidence rate ratio, where we compare short-term to the long-term. We can see in all the groups, the IRR are all greater than 1. So it implies us that the misdiagnosis does exist in all specialties. After we understand this, we need to answer the second, is our main question. Is the diagnostic accuracy different among these specialties? In order to answer this question, we need to reduce the referral bias we mentioned. How to reduce the referral bias? Here we choose the method, we call it propensity score matching. As we know, propensity score matching can reduce referral bias by adjusting for many covariates without losing too many sample size. So we calculated the propensity score at first with the 31 covariates, including some demographics, cardiovascular risk factors of mortalities. And then we did one-on-one propensity score matching to compare the stroke risk between specialty care group and general care group. And we use the specialty care group as the reference. Okay, let's see these two figures. Before propensity score matching, the cumulative stroke incidence curve were diverse between general care group and specialty care group. These figures tell us that the baseline stroke rates between general care group and specialty care group are different. However, after we did propensity score matching, we can see this cumulative curve became parallel. That's amazing. So this implies us that the baseline population difference has been eliminated by the propensity score matching. And what about the initial difference? Actually, the initial difference is what we want, meaning the difference of misdiagnosis. Okay, let's see the quantitative data after propensity score matching. When comparing specialty care group to general care group, the relative risk of stroke at 30 days after benign vertigo diagnosis is 0.57. So it tells us that indeed, specialty care group had lower stroke risk than general care group. But about the long-term relative stroke risk at the 90 days or at 1 year after benign vertigo diagnosis, were not so relevant as the short-term relative risk of stroke. So in conclusion, risk of stroke following benign vertigo diagnosis is highest in the first month, suggesting that misdiagnosis does exist in all clinical settings. However, the population difference in different clinical settings suggests referral bias, so we use the spatial statistic method, propensity score matching, to adjust for the referral bias and show that the stroke risk is higher in general care group and lower in specialty care group. So we concluded that the general care providers may benefit from improved education, training of otolaryngology, or we give them a diagnostic decision support for diagnosing dizziness and vertigo. Thank you for listening.
So questions, please?